This podcast focuses on the pediatric hand exam. Our faculty member is Dr. Donald Bay from the Department of Orthopedic Surgery.
Each of the fingers has two sets of tendons that flex. And one tendon flexes the most distal joint, the distal interphalangeal joint, and the other tendon flexes the proximal interphalangeal joint. So it's fair and proper to examine both tendons if you're examining a child's finger to look for a flexor tendon injury. So how do you do that? You have to isolate the affected digit and the affected joint. So let's say I wanted to test the flexor digitorum profundus tendon to Cole's long finger, and the flexor digitorum profundus tendon flexes the distal interphalangeal joint. I would hold his fingers like this, and Cole, wiggle the tip of your finger for me. And so the fact that Cole can wiggle that distal interphalangeal joint and flex it down tells me his FDP tendon is intact. So too, by holding the other fingers and asking Cole to flex his finger down again, that Cole can also in isolation flex his proximal interphalangeal joint. And that tells me that the other flexor tendon is working, and that would be the flexor digitorum superficialis. You have to isolate the other fingers, however, because these have a shared muscle belly, and the patients will try to fool you and cheat the exam by recruiting the other muscles. So it's really important to hold the other fingers still and to check them in isolation. In extension, you can also test the very same. So Cole, can you straighten your index finger out? How about just your pointer finger like this? Very good. So although there's one extensor tendon, it turns out there are multiple slips and expansions, each of which extends a different part of the joint. So if you're going to properly examine the motor function to the finger here, you want to test resisted extension at the distal interphalangeal joint, very strong, my goodness. Test extension at the proximal interphalangeal joint and at the metacarpal phalangeal joint, because you can have two of the three normal and still have an extensor tendon problem. So that's a brief look at the flexor and extensor motor groups. Another thing we can talk about a little bit are common deformities we see and provocative testing that we do. So some of this falls under the auspices of inspection. One of the great tenets in orthopedic surgery is that orthopedic injuries hurt. And so oftentimes if you can isolate the structure that's affected, you can elicit some degree of tenderness. We talked a little bit before about the scaphoid tubercle in the anatomic snuff box. We talked a bit about the pisiform and hook of hamate. One of the things that oftentimes we see are patients who come in after jamming injuries from sprain-type injuries. And so the other thing you want to check for is instability. Instability testing depends a little bit on which joints you do. So we'll just go through that real briefly. In the metacarpal phalangeal joints, including the metacarpal phalangeal joint of the thumb, you want to isolate that joint, and to test its stability, test both radial and ulnar deviation of that joint in extension and 30 degrees flexion. It turns out that the collateral ligaments are fan-shaped, and you need to test both in extension as well as flexion. Sometimes we're faced with a swollen digit after a jamming type injury. We stress them in extension and flexion, and we worry if there's a collateral ligament injury, yet we don't know what's really normal for the patient. Certainly you want to go to the other side. And in general, if you have more than 15 degrees of difference or more than 30 degrees absolutely of laxity, that's very concerning for a collateral ligament injury. In the interphalangeal joints of the fingers, oftentimes hyperextension instability is seen, and so by gentle stretching of the fingers and hyperextension, you're looking for a firm endpoint and no obvious pain or instability.